Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Sukhpreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Hello and welcome to the MenopauseWize podcast on GLP-1s, everything you need to know to get started with Dr. Michelle Gordon. Dr. Gordon is an obesity, menopause, and lifestyle medicine expert who is board certified in obesity medicine, lifestyle medicine, and general surgery. After 15 years as a general surgeon, she shifted her focus to women's metabolic health, recognizing that many chronic diseases are best addressed long before patients reach the operating room. Today, she helps high-performing midlife women feel like themselves again through her understanding of complex physiology and pattern recognition by supporting them with compassionate evidence-based care. So welcome, Dr. Gordon, to the MenopauseWize podcast. It's so exciting to have you here. I've been listening to you for a while now, and thank you for being here and willing to bring some more clarity to weight management and the use of the newer drugs. So thank you.
Thanks for having me.
Well, so before we get into the drugs available and the GLP-1, the list of drugs available, I'd like us to spend a little time on what we really think about obesity. And I've heard you often say on your platform that obesity medicine should be grounded in physiology and not shame. And I absolutely love that tagline. But if you could expand what you really mean by that.
Well, it comes from it really starts with religion, believe it or not. Because in the Christian religion, sloth is a sin. Okay. So it's one of the 7 deadly sins. And we have this moralization that comes with anyone who doesn't fit the mold that we expect in society. And that's where the physiology, not blame, comes from. Because when you have a problem that you're trying to fix, whatever it is, and in this case, we'll pick obesity. I don't know one obese person who hasn't tried to lose weight repeatedly and just could not because of their biology. Some people are able to. Some people really are able to keep weight off and put weight on for whatever reason and then take it off. But for the most part, the body, once it gets up to a higher weight, will always defend that weight. Will always try to get you back to it. That's biology. That's evolution. That's living in feast and famine. How we evolved through our pre-industrialization. So that's I think where we have to start. I mean, we have to start in ancient beliefs, and to look at obesity as a chronic relapsing disease requires a complete paradigm shift. And there is not any time that I put a post up where there isn't somebody, man or woman, usually a man and usually a gym bro, but sometimes women and sometimes women who have like internalized misogyny, who will come at us and say, well, if there's no obesity in concentration camps, there's no obesity in starvation. And duh, it's starvation. And I think that there's also this argument that, back in the 70s and 80s, there wasn't as much obesity, and that's true. But we also live in an obesogenic environment, and we live in North America where it's the land of the corporation and the home of the profit, and they don't care about your health. And so everything that is put in front of us is for consumption. And it's to squeeze as much consumption out of us as possible. That's why McDonald's has a whole food lab dedicated to hitting the pleasure centers of your brain.
Which brings us to the concept that obesity is recognized as a chronic multifactorial disease. And considering it is multifactorial, we are looking at weight management obviously follows that it cannot be as simple as calories in, calories out, or eat less, move more. And I know that you have emphasized on your social media platform repeatedly about how we need to look beyond calories in, calories out, and how biology is beyond just the basic laws of thermodynamics. And could you tell us something more about that?
Yeah. So, what I will say, and I want to start with this premise, you have to be in an energy deficit to lose weight. There is energy balance is real. There is no way to lose weight if you're not in caloric deficit. The issue is that what that caloric deficit is for an individual. In a woman in perimenopause whose hormones are going different, or a woman who's postpartum, or a woman who has given birth, that's a huge physiologic shift. Women go through massive shifts that are never even thought of by men. And we go through them every month throughout our childbearing years. And then we enter perimenopause where everything becomes chaotic, right? And that's where the energy burn goes down, the amount of movement actually goes down without us even knowing. So it's multifactorial. And weight comes on. And so we think we're doing everything the same, but the weight piles on anyway because of hormonal shifts and because of actually less fidgeting, less movement that we don't even notice. All right. And that's why I think calories in, calories out is not the best model for a midlife woman who's struggling. She's already dealing with a shame spiral anyway. Why can't I lose this weight? I can do everything else in my life. I can't lose this weight. This is so frustrating. And remember, the body's not a kilometer. We're not a closed system. And anytime a gym bro comes back and says thermodynamics, bro, it's just so simplifies the system because they're not taking into account the huge hormonal shifts and what biology is doing, and then what the neurological system is doing on top of it. Because anytime you start eating in a deficit, your body fights to get you to eat more, from the brain all the way down.
And I know that you've spoken often about what really goes off in midlife, right? Like I've heard you talk about the, how women, and we're hearing this repeatedly in clinical practice as well, women coming and saying, hey, it did work in the past, calories in, calories out. But now something's shifted. It stopped working. I can't lose weight as quickly as I could. So what really happens during midlife or during perimenopause for women that changes that equation?
Well, there's metabolic adaptation, and there's just less calorie burn that happens in perimenopause and menopause. And again, like I said, we move less. We may think we're moving more, but we actually move less. And as we age, if you look at people throughout history, like let's say you go to a park, and you see a child always moving, right? You see somebody in their 20s, they're riding a bike or moving or something. As you watch people who are getting older, people sit. And we just don't even notice it. So one of the best things you can do to combat this is to, number one, work on your muscles. Make sure that you keep your muscle tone, and that's lifting weights 20 to 30 minutes twice a week. We'll do that along with eating adequate protein. Those are the things that are going to help preserve your muscle mass. Adequate protein is so the data are mixed, but the recommendation is 0.68 grams per pound of ideal body weight of protein. That's a hard number to get at. So it's about a gram per kilogram of ideal body weight, but nobody wants to think in kilograms in America because we're backwards. So I just tell women to try for 100 grams of protein a day as a general rule of thumb, because it's ideal body weight. It's not current body weight. Like if you weigh 300 pounds, don't eat 300 grams of protein.
And what about appetite and insulin resistance? Do they have a role to play in midlife and women going through perimenopause towards their weight?
They do. Appetite does seem to increase a bit, and we don't understand why. There's a lot we don't understand about women. We have to preface everything there. And why is that? Because we never studied women. In 1993 was when women had to be included in clinical trials, and they were excluded because the hormones were too complex. Okay. So we're just now starting to understand more about women. And I think it took Gen X making a big fuss going through menopause. Like, this is crazy. Why should we have to suffer through this? to really push on the research. But when it comes to insulin resistance, it's a very tricky thing, because loss of estrogen does affect insulin handling. It also affects bone handling, and it affects your brain. And there's so much you can do, that there's so much that it does in your body. And we don't fully understand why we go through menopause. But as far as I know, there's only a couple of species that go through menopause, that is whales and humans. And whales are a matriarchal society. Now, I don't think elephants do, and they're also matriarchal. So I don't know. I'm not a wildlife biologist, but we do know that whales go through menopause, and they do that so that they can go out and kind of lead, right? And so you wonder, why is it that the reproductive time stops for women? What is the purpose of that? Because if our role was to serve, we wouldn't be fighting against the patriarchy every day.
That's
Right?
true. That is true. That
So,
is true.
so again, I don't have all the answers. I don't know. But what I can say is that the loss of estrogen does lead to some insulin resistance, some difficulty with cholesterol management. And sometimes when we can get those hormones replaced, kind of nip that whole metabolic chaos that happens in the bud, but not always.
The primary complaint of a lot of women is about weight, not only weight gain, but change in body composition, increase in fat around the belly. But where does the role of these drugs start off? The GLP-1 drugs, how do they work, and how are they different from drugs that we have used in the past?
Before GLP-1 medications, we had appetite suppressants, which were primarily stimulants, and you can only take them for a short amount of time. We have other drugs like orlistat that is still talked about, and it was tested in the obesity boards. And orlistat it delays or hinders fat absorption. So let's say you take orlistat and you go and eat a pizza, then you're going to have greasy stools and probably have diarrhea for the next hour or two. So it's a really terrible drug in terms of lifestyle, right? Because it just impairs fat absorption. That was an early one. And then we had the over-the-counter ones. We had fen back in the day, but it caused I can't remember the name. Do you remember fen?
No, not at all.
It was phentermine and another fen, and I can't remember the other fen, but it was the other fen that caused heart problems. And now we use phentermine by itself or with topiramate, and that's in a drug called, and that's a stimulant along with topiramate, which is an anticonvulsant, and it works on the brain to kind of decrease reward when it comes to eating, but it also makes you stupid. So at high doses, topiramate makes it so that there's a lot of difficulty with cognition and word recall and things like that. So that's for that reason I don't use it. And then other drugs that we have is bupropion naltrexone combination called, in the trade name is Contrave. That drug works on the reward center as well in the narcotics kind of receptors, and it blunts desire for the cravings. And it can work, but again, these drugs are successful when you have a 5% body weight reduction, right? So lo and behold, back in the 80s, somebody figured out that there was this molecule called GLP-1, and it was a woman. And the problem was that it just didn't last very long. It lasts about 2 minutes, 90 seconds to 2 minutes in the body, but it's released after you eat, increases satiety for 2 minutes. Not long enough. And then later on, another woman figured out how to package it so it would last longer. And we've been studying them since the 80s. But one of the side effects was all these GI side effects, right? Like the constipation, the nausea, the diarrhea. And people weren't able to tolerate them. And then somebody had this idea like, well, what if we titrated? So here we are. So we had liraglutide, which was a daily injection, which is also Saxenda. And it was I think a 7 to 10% weight loss, daily injection, high side effect profile, lots of nausea, and people took it, but they weren't really happy about it. And then we got semaglutide, and both of these are GLP-1s, packaged differently with different half-lives. So liraglutide has a half-life of 12 to 13 hours, which is why it's a daily injection. Semaglutide has a half-life of about 6 days, and that's a weekly injection. And that's the Ozempic craze. That's when we really started seeing that it would work on weight loss, but it also works on blood sugar. And that's why it's now the first line for type 2 diabetics, because it works in managing blood sugar in the face of high blood sugar only, which is super exciting and cool. And with semaglutide, the weight loss is about 15% over 68 weeks in the studies. In real world data, people can lose more than that. They can lose a lot if they tolerate it. Still has a pretty high side effect profile, a lot of nausea and queasiness. But I have some patients who tolerate it better with better appetite suppression than, say, tirzepatide. So it's so individualized because nobody is exactly the same, which is why we have to have individualized medicine with these drugs. And we have tirzepatide, which is GLP-1 and insulinotropic polypeptide. That's probably my favorite drug right now. It's approaching bariatric surgery levels of weight loss, up to 22% in some studies at 72 weeks. The issue, well, there's not an issue, but what I really love about it is people tolerate it better with fewer side effects. But these drugs don't work on everyone. About 9% of people don't tolerate, or they don't work for. And then we also can have some side effects. And the side effects can be pretty severe for some people. I mean, pancreatitis, gastroparesis, with paralysis of the stomach. There's a couple of absolute contraindications. One is if you have a history of multiple endocrine neoplasia type 2 or medullary thyroid carcinoma. The thing is those studies, the medullary thyroid carcinoma was found in rats or rodent studies only. It wasn't shown in humans. And a lot of people have taken this medullary thyroid carcinoma and said, if you have any family history of thyroid cancer, you can't take this drug. And that's wrong. That's not a contraindication. The contraindication truly is if you have a personal history or a family history of multiple endocrine neoplasia type 2, which is a super rare genetic disorder of the endocrine system that leads to medullary thyroid carcinoma, which is also like the rarest thyroid carcinoma of them all. So that's kind of the overview of the drugs. So who's it for? It really depends on who it's for. So it's not really, if you want to just lose 5 or 10 pounds because you're going to an event, that's not the right thing. If you have visceral fat, if you have high metabolic markers, if you have metabolic syndrome, then it's probably something that you should discuss with your doctor. The thing is that there's a lot of anecdotal evidence from the bodybuilding community on these drugs, because bodybuilders have to deal with hunger. And most of the time they deal with hunger through sheer willpower. And that's very hard because the brain is powerful and hunger is controlled through the subconscious. And so they'll use these drugs, and they'll use an experimental drug called retatrutide, which has not yet been approved by the FDA, but you can get it on the gray market. I don't advocate for that, but I do know people who use it, and I follow, these Reddit forums to see what people are talking about because I want to know. And what's really interesting about retatrutide is it's GLP-1 GIP, so it's the same thing as tirzepatide plus glucagon. And I'm very excited about this drug because it helps with the fatty acid mobilization at the portal vein. And what's really cool about that is if you can manage that, then maybe your lipids will come down and maybe you won't lose as much muscle. And that's what I'm really excited about when it comes to retatrutide. For the most part, GLP-1 medications, the criteria that we're working with right now, BMI of 30 or above, BMI of 27 with a comorbidity. Okay. BMI is terrible. I hate it, but it's what we have. It's a population study. It was done on white people in the Netherlands in the 1800s. So it doesn't really port out. Even the normal BMI for Asian people, for example, is like 18. And obesity starts at 25 for Asians. But it doesn't take into account how much muscle mass you have. It doesn't take into account that the body composition at all, which is why I hate BMI. I like waist to height ratio
Right.
best.
Right. And I've always wondered about the decision for starting these drugs. Should it just be BMI? Because right now the criteria, clinical eligibility is BMI. But what about the lean woman or so-called lean woman who is, let's say I have a BMI of 23, but body fat percentage of like maybe 45%. We've seen enough of those. And maybe a high visceral fat. Am I a candidate for these drugs?
I think that's individualized. It would certainly be off-label. So we don't have any FDA indication for that patient population. But, the question I would have is, are you struggling with eating? Because remember, these drugs work on your appetite centers. They decrease your hunger. And somebody who's a BMI of 23 with 45% fat and maybe 4 pounds of visceral fat, they need some intervention. But the first intervention wouldn't necessarily be a GLP-1. The first intervention would be more movement. That would be what I would go for: more lifting, more walking, and then a truly dietary overhaul, or at least a dietary evaluation to see before I started a GLP-1. Because GLP-1 medications are lifetime. It's not a drug you start and stop. Just like, you start a antihypertensive, most likely you're never going to come off of that. The only reason you would ever come off of an antihypertensive is if you lost weight, because weight loss can make it so you lower your antihypertensive. But let's say you're on a thyroid medication. Most people who are on thyroid medication are never able to come off of it. So it's the same sort of thing. So for somebody in that specific scenario, my first choice would not necessarily be to reach for a GLP-1. It might be to reach for an appetite suppressant for a little while. If it depends on if it's appetite, it would be, I'd have to talk to the patient and see what their goals were and all those things. But movement would probably be the number one thing I would work with, because you don't get to a visceral fat of 4 pounds and a body fat percentage of 45% if you're active.
Absolutely. Absolutely. Well, that's great to know. But what about a woman who says, let's say, a BMI of over 30, but says she's not really eating much because, let's say she's really not eating much, and we go through her diary, her food diary, and she's really not in excess calorically. Is there a role for GLP-1 drugs for her?
Yeah, actually there is, because of the improved insulin management. Because a woman who's a BMI of 30 probably has metabolic syndrome, probably has insulin resistance, leading towards pre-diabetes or diabetes. And the best way to know about that is like a fasting insulin, but not very many people do fasting insulins. So, but you see in perimenopause that will rise long before the hemoglobin A1C does. Yeah, I think for someone like that, a GLP-1 would probably be a good idea. Again, the bigger question is, what is the patient's goal? What does the patient want? I mean, you can't do evidence-based care without involving the desire of the patient.
Right. And if you're looking at, like you've discussed the indications or when to start, on complete the absolute contraindication. Next, we come to how do we decide which one? I know you covered a few areas, but how do you actually decide which drug goes for whom?
So my clinical experience is that I usually, if I'm working with a man, I don't have a lot of men in my practice, but I worked at a big telehealth company, so I had maybe a 10% male on my panel, and I always started men on semaglutide. They seemed to tolerate it better. They didn't have as much nausea. They had pretty good weight loss, and it was less expensive. It's still less expensive, and actually in parts of the world, it's generic now. So I think in India, for example, I think you can get it for $30 a month, maybe even less.
Yes.
So that would be, if cost is concerned. So I find that men tolerate it better. And of course, we don't know why. I mean, we haven't done the sex-specific data. There was a post hoc, like some sort of a meta-analysis where they pulled data and saw that women lose more weight on these drugs than men when they pull the women's data out. But for women, it's usually tirzepatide is what I use. And they just seem to tolerate it better. It doesn't up in their lives. in the same way. But not everyone, it doesn't have, I have a couple of patients that are on, that I have on high dose Wegovy, which is the 7.2 milligram, that because they just were not getting the appetite suppression they needed on tirzepatide. And so again, it has to be individualized.
And we often hear about microdosing. What are your thoughts about it?
So when it comes to microdosing, I think if you're really sensitive to the medication, starting at a very low dose and then titrating from there is probably a good idea. When I started taking tirzepatide myself, I started at a low dose. I started at less than 2.5 milligrams. I was really afraid of it. And I stayed at 5 milligrams for a good 4 or 5 or 6 months. And had really good results from that. And then when I went up in dose, I didn't see any change. So it's like, well, why go up? Because it didn't give me any difference in my appetite suppression, which I thought was really interesting. That's my personal view. Some patients at the starting dose don't tolerate it. They have really difficult side effects. So those people, I start at a lower dose. And what I like about vials is you can actually really personalize the dose. It's much harder to do that with the auto pens the manufacturer makes. So there are some people who will take start with a 2.5 and get violently ill. Those patients, I'll usually send, I'll have them buy a compound, and then I'll lower their dose and then slowly go back up. And then once they're at a normal dose, we'll look at going back to the name brand, or if they're tolerating the compound, they stay on the compound, and I leave it up to them. But that's where compounding is really helpful, I think, because you can personalize the dose in a way that's not possible. With the Zepbound vials, you can do that a little bit, but they're supposed to be single use. But microdosing for some people, I did an article on Substack about microdosing because it's one of these things I just keep getting asked all the time. Along with, can you reset your body set point? No. I mean, short answer to this, can you reset your body set point? The answer is no. But if you take GLP-1 and don't stop it, then yes, right? But I did this article on microdosing, and there are some indications. So women with PMOS, for example, I've had plenty of women who take GLP-1s who have PMOS that completely manages all their symptoms. They get back to a normal period. Some of them get pregnant, which they never never thought they would be able to do. People with certain types of like rheumatoid arthritis and other inflammatory conditions find that their inflammation really goes down with it. But interestingly, I also see perimenopausal women who have a lot of the inflammation or anxiety or whatever, and as soon as we get their hormones right, a lot of that stuff fades away. And so it's kind of a 6 of one, half dozen of another. You really, there's a lot to do when you're doing personalized medicine.
So there seem to be a lot of trickle-down effects of using GLP-1s. We're hearing a lot about reduction in inflammation and sleep apnea and other impacts of using these drugs. Is there some evidence of it working directly on other aspects, or is it actually trickle down on weight loss?
What we do know is that in the SELECT trial, that was semaglutide, cardiovascular benefits were independent of weight loss. Sleep apnea benefits are usually a result of weight loss. And we know that diabetes and heart disease reduction decreases 5 to 10%, decreases a lot with a 5 to 10% weight loss. So weight loss is the driving factor for most of the improvements, but we also know that you can get some heart health benefits without any weight loss at all. And that's why if you feel like your GLP-1 isn't working, don't stop taking it, because it's doing stuff behind the scenes, even if it's not suppressing your appetite, or you start noticing that the cravings come back and whatever, it's still doing all the things it does.
I guess it's in some way for a woman who is on MHD and says, but I don't have hot flashes, but it's still working on bone health, and for her to understand that is so important, that it's still working. But then coming to expectations, let's say, how do you start with counseling women who see you about what is a practical way to expect weight loss or manage her weight when she starts?
So, I think it's really important to understand the concept of enough. you might have a goal. Let's say you want to get back to your high school weight. You're 5'5", you were 130 when you were in high school, and that's your goal weight. That's when you felt the best. But you're 250 pounds now. Is it possible? Maybe. Is it probable? 20% weight loss is exceptional on these medications. And obesity is a chronic relapsing disease. Your body's going to fight to go back to higher weight no matter what. So if you can lose 20% of your weight and get healthier, then that may be enough. And so I try to temper expectations with that. I always ask my patients what they want. What does success look like to you? And then we try to get there. Sometimes we don't, sometimes we do. It all depends. We can't determine what is going to happen. And not everybody responds, 100% to these drugs. And so it can be very frustrating for someone. I try to temper the expectations. Number one, people on the internet lie. They say they lost 30 pounds in a month. If they lost 30 pounds in a month, they're probably going to get their gallbladder out, right? Because rapid weight loss leads to gallstones. So we have to be really careful about how we compare ourselves to others. Your journey is unique to you, and comparison is the thief of joy. And so be happy in your moment, enjoy your journey, try and love every second of what's happening. And, we have medications that work. But again, you're taking these medications and there's side effects and there's risks. And so we go through all the risks. We talk about pancreatitis and we talk about gastroparesis and we talk about, the optical neuritis that can happen, primarily with tirzepatide, which is, all of these things are rare, but they do happen. The biggest issue for me is if you take too much medicine, that's when these things happen. So if you try to titrate too soon, or I think one of the biggest things that can happen is titrating too quickly, trying to go up every single month and getting to the max dose, and then that's where you can't go any higher after that, right? And so my philosophy on these medications is we stay at the lowest dose for as long as possible until you start having so much hunger that it's not controlled. And then after about 3 or 4 or 5 days, if you're starting to have a lot of hunger, or you're starting to slide back into habits that you thought you didn't have because your brain will always try to get you back to your old weight, then that's when it's time to increase dose.
Yeah, again, once again, it's like somewhat like NHD, where we start low, go slow till you feel comfortable with that particular dose. But what are the side effects that one would experience initially while starting off that you mentioned?
Yeah, common side effects: nausea, constipation, diarrhea. Those are the main side effects that I see. Abdominal pain sometimes. And these are all mitigated by, nausea. Number one first line treatment for nausea is ginger. It's my favorite. Yeah, it's my favorite first line treatment. Ginger will decrease nausea. You can use ginger capsules, you can use ginger chews. Now, not everyone, it doesn't work for everyone. Some people really hate ginger, some people are allergic to ginger. And then you can use like Zofran. But the issue with Zofran is it's a 5-HT receptor agonist. Yeah, so it decreases nausea. It works great, but it can cause worsening constipation. And so I really try to keep people off of that. Constipation is a problem. You can manage constipation with all sorts of over-the-counter remedies: Senna, Miralax, more fiber. I really like psyllium husk for fiber. Gut health is really important. It's important, to make sure that your gut microbiome is healthy. And the way to do that is to make sure you're eating lots of yogurt and fermented foods and lots of fiber. The best thing you can do for your gut is to increase your fiber intake. I'm not a big fan of, stool testing and that sort of thing, unless I think you have a parasite.
Right. And so what I hear you saying is that, yes, you may be on these drugs, but you've still got to support your body with the right foods and the movement, the exercise. It's not just use the drugs and you're okay.
Yeah, well, and the thing is the studies are now showing that most people who use these drugs are not moving much. And probably what we're going to see in the next 5 to 10 years is a lot of osteoporosis and other health problems because people aren't moving. Without resistance training, without eating adequate protein. And you have to do them together. You can't just eat protein. You have to move. And movement can be whatever it is you want. I mean, if you like to walk, then walk, and maybe wear a weighted vest to put a little bit more load on your legs. You know, whatever kind of movement you like. I do prefer that you do some resistance training a couple of times a week, but that's because that's what the data show us from the MRI studies. You lose 1.5% of your muscle every year from menopause on. And so the way to stop it is to eat protein and lift weights. And the only way, the problem is that when you're taking in something that suppresses your appetite, it's hard to eat to support your muscles. And so when I get somebody at maintenance, what I'll do is I'll use the medication as a lever I'll decrease it so that they can eat and then work out really hard and build muscle. And then we'll increase it if they want to, if they start noticing that they're gaining a lot of extra fat.
Yeah, I guess for women in midlife, that becomes a bigger concern. It's always a big concern for me when I'm seeing someone on GLP-1s and they're using hormone therapy to support her bones to prevent osteoporosis. And then you're looking at her not eating enough because her appetite is suppressed because of the drugs. And there's always a sweet spot for us to work in collaboration with someone who's prescribed her those drugs to see, hey, what's really going to work for her, as opposed to, I've just got to lose weight. And
right. We have to stop focusing on the number on the scale. We've got to look at body composition. That's got to be number one. And that's why I like the waist to height ratio. You want that 0.5 or lower. That indicates metabolic health. And so that's something that's really important. And, if you're going to look at BMI in conjunction with that, then, the lowest BMI you really want to get to is about 22. You don't want to go much lower than that, because when you go lower than that, then there's a lot of health problems.
So we are looking at a J-shaped curve where there is, again, a sweet spot for BMI and bone health, as opposed to just being too lean and then suffering from poor bone health. So the other concern, which I know you mentioned earlier about, is the use of these drugs long term. Do I have to be on GLP-1 drugs for life once I start them? How do you counsel a woman who has that concern, and what's your advice?
I look at it from this perspective. If I diagnosed you with diabetes, would you ever ask me if you were going to be able to stop your insulin? If I diagnosed you with hypertension and said, you have got to take this medicine every day now, because if you don't, you might have a stroke. So I like to compare it to other chronic diseases. We treat them for life. If you have this goal of coming off this medication, well, let's go back. We have this thing about weight loss that we think that if we take something, it's temporary, and then we can stop and everything will stay the same. Everything will, if all I do is work on my habits. Okay. The problem is hunger is driven by the brain, and you can't control that side of your brain. It's subconscious. I mean, 90% of what we do is subconscious, right? We don't think about breathing. We don't think about, our digestion. Right. These are processes that are running without any conscious thought. And hunger is one of those. So when you take the GLP-1, that is what manages the hunger centers. Okay. You take away that treatment, then hunger is going to go back up. And a lot of people have, what's the term? FAFO. You know what that means?
FAFO? No.
Look around and find out.
Ooh. Nice one.
Yeah. So basically, a lot of people have tried this. And I've seen the because I read Reddit posts, and then I have people who talk about it on my pages, and they'll say, I really thought that I had it under control. I was doing great. I wasn't eating much. And I really thought I could come off this medication. And then they come off of it and the weight comes back. And in the data, but the studies show that in the first year, 2/3 of the weight will return. 2/3 of the weight you lost will return when you stop the medication. I wrote an article on Substack called In My Practice. It's like, if you don't stop without a plan, something like that. But basically what it is a guide to maintenance on GLP-1s. 17.5% of patients who stop medication are able to stay off it and keep the weight off. There's not a lot of difference between them and anyone else. Maybe genetics. It's not habits. So if you do come off the medicine and you plan to come off of it, you want to come off of it over 20 weeks, not abruptly stop. So a slow taper, and work on, in life, you do get your habits. I mean, habits are a big part of it. So if you do this, if you take the medicine and don't change any habits, don't change how you're eating, just eat less of whatever, then yeah, you're going to have a lot of trouble when you come off. But if you take this time to when you have this free space in your brain where you're not thinking about food, and you go and you start lifting, you start walking, you start learning how to move better, you start learning how to eat better. And, a lot of women in my community will say things like, I never knew I could have this much expansion because my brain isn't thinking about food all the time.
Right. So are you saying that there is a possibility that a woman could, and I'm only talking about women here, a woman could get onto a drug, onto one of these medications and be on it for maybe a couple of years, and over 2 years has really made drastic changes in her habits and built some muscle mass, gotten rid of visceral fat. And if she does think about tapering it off, is that a possibility, tapering it off and still maintaining?
It's a possibility, right? But again, it's only 17.5%. So it's a low process. It's less than 20% of people are able to do that. Right. So my philosophy is, if you really want to come off it, then I'll work with you to come off of it. But we have to, when we decide for you to come off, we set a threshold of weight gain to go back. And the problem is that when you stop these drugs and come back, they don't seem to work as well. And we don't know why.
Really?
Yeah. And so it's a risk. It's a big risk to stop and then have some weight regain and then come back and take it again. And then it doesn't work as well. And, you're frustrated because it worked before. There's some people, some influencers say, well, yeah, you got to clear your receptors every 6 weeks. And that's nonsense. Don't do that because you're going to end up it's not going to work. So I really, again, evidence-based medicine has a lot to do with what the patient wants. If I'm working with a patient who really wants to come off of it, then I'm going to work with them, but we're going to set a threshold. My personal philosophy is probably I wouldn't try to come off of it.
That makes sense. Before we wrap up, I would like to leave our listeners with a few practical takeaways. So if you had 3 key takeaways for our listeners today who are considering getting onto a GLP-1, any of these drugs, what would they be?
I think the first thing I would say is, we're talking to women, right? I like to look at the perimenopause and menopause time as it's our time. Okay. We have spent our lives serving the men in our lives, our children, and now this is your time. Advocate for yourself and do what you want. It's super important. I mean, this is your time for you. There's a book that I recommend often by James Altucher called Choose Yourself. That book changed my life. It helped me to start to choose myself in where I was. And I was in this, really weird place where I had left surgery and I wasn't sure what I was going to do. And I thought I was going to do coaching, and and then I fell into obesity medicine. But that book, I didn't even know I was in a depression when I read that book. And that book really helped me. So I like that book. I think it's very important for us as women living in a patriarchy to choose ourselves and to advocate for ourselves. Obesity is a chronic medical condition. It's not a character flaw. It's really important that you stop blaming yourself for this. Maybe you're like me, you had a baby and you just were never able to lose the weight. And I didn't, at 32 years, I thought there was something wrong with me until I started taking tirzepatide, and I was able to get back to my pre-pregnancy weight pretty effortlessly after trying and starving and all the things and feeling like a failure. So if you don't get anything else, get that. It's a chronic medical condition. Another thing is GLP-1s work, right? But you need a comprehensive plan. And so you can go to a telehealth provider and get a medication, but if you don't have a comprehensive plan, it's going to be a problem. And so, if you can't afford personalized medicine, then, join my Substack or work with, follow people who are helping you to develop this whole comprehensive plan so that you can have the most success possible. It's a marathon. It's not a sprint, right?
Yes.
Don't compare yourself to anyone else. Your weight loss is going to be yours. Your journey is yours. There's only one of you. and you are different from everyone else in the world.
I love that. That is amazing. There's only one of you, and that's a great takeaway.
Yeah.
So thank you so much for this incredibly informative conversation. And I'm sure our listeners are going to go back with less confusion and less misinformation, and they are going to be able to have a better, more meaningful conversation with their own healthcare providers about this. And for all you listeners, please do follow Dr. Michelle Gordon on her Substack. She's amazing out there, and she shared some statistics with me, which were quite amazing. Would you like to share those? Your Substack?
Oh, my statistics on, yeah, I started Substack on April 4th because I wanted to I don't know, I had a gut feeling that it was probably the right thing to do. And since April 4th, I've been #1 in rising health and wellness about 5 or 6 times. But what I'm most proud of is that I'm number 36 on all of health and wellness in the Substack bestsellers. I've grown my list from me to almost 12,000 in that time. So people are listening, and but I also I'm closing in on 1,000 subscribers, people who are paying me to do the writing and to interact with them, which I think is super cool. And so,
That is amazing. That is so
Yeah.
amazing. Congratulations on that.
Thank you.
And,
Thank you so much.
Thank you for sharing. Thank you for all of this today, this wealth of information, and I'll stay connected.
Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.